that internationally the world looks up to, because we've used very robust methodology and also for the kind of algorithm that we have proposed. And I had the honor, along with Dr. Rakesh Garg, to present these guidelines at the recent World Airway Management meeting in November 2025, when this guidelines was just released, and I was given the opportunity to present the guidelines in front of all the global airway experts. So just to set the stage, I just want to put up this cartoon, and this kind of clip, in a second gives you an image, and this is a situation none of us want to be in, and we always think that this is not going to happen to us ever, and definitely not today, right? And you can see the patient is all blue. You can see the saturation, you can see the heart rate, you can see the operator. Just look at how much he's sweating, and you can see the assistant. And not only the two airway operators, but also the sweepers and the OT assistants are all stunned. And this is the kind of situation that we really don't want to be in, the unanticipated difficult airway. And what we have to know, not only with the anatomical preparation for the airway, is that there is a lot of cognitive overload at this time. So it is a technical as well as a non-technical skills that we have to be prepared for during an unanticipated difficult airway. And that is what the AIDAA guidelines try to address. The human factor considerations that are very important at this time, because you're not able to think straight. There's so much cognitive overload. You think, oh my God, I'm not going to be able to secure the airway. This patient is going to get hypoxic, probably brain dead, maybe even die. I'm going to lose my job. What are people going to think about me? So there are a lot of thoughts, and it's well known that there's tube vision. There's so much cognitive overload. We keep repeating the same thing again and again. And sometimes what happens is a very junior colleague comes in and says, oh, why don't you put in a supraglottic airway device? Or why don't you do this, right? And that is the exact situation when there is, and we have to think about the human factor considerations. So what these guidelines try to do is, the guidelines are trying to help us in a structured way overcome this situation when you have an unanticipated difficult airway. And I'm going to be, talking about the adult scenario. We also have guidelines for pediatric obstetrics and extubation as well, but that will be covered in different sessions. So just to give you a bit of the background, so we had a previous iteration which was published in Indian Journal of Anesthesia. We published adult, obstetric, pediatric, and extubation guidelines, and also the first guideline for tracheal intubation in the critically ill patients. So it was a very ambitious project. We had 6 guidelines that were published in parallel, and no airway society in the world had done this together, and it was a mammoth task at that time. So what were the highlights of these guidelines that we had? I'm sure all of you have seen the 2016 guidelines. It was the first time that India had national airway guidelines from a national society. So the unique feature of these guidelines was we gave a lot of emphasis on peri-intubation oxygenation. Limiting the number of attempts at diverse insertion. So we said no more than 3 attempts. The other unique feature was we set a saturation threshold of more than 95. So most guidelines tell you 2 attempts, 3 attempts, but that doesn't mean you just go on and on and on proceeding with 1 attempt. But we said that you don't proceed to the next attempt unless the saturation is more than or equal to 95 with the next device insertion. And that's really important, because you do 1 attempt and then the saturation is, say, 70, you're not going to go ahead with the other attempt unless you reoxygenate the patient. And we also defined a new term that got a lot of global attention, and this was complete ventilation failure, which I'll talk to you in a bit. We also talked about calling for additional help during complete ventilation failure. And this was another unique feature, because we already have calling for help when you encounter the first difficulty. But we said before you proceed to do an emergency cricothyrotomy, when you face the complete ventilation failure scenario, you should call for additional help. And the reason for this is not only to get an additional helping hand, but it is also to overcome those human factors that the additional hand might actually come and think in a different way, and that person is not part of the stress. And this actually was appreciated by the American Society of Anesthesiologists. And when the ASA difficult airway algorithm was made, they incorporated this calling for additional help prior to doing the emergency cricothyrotomy. And then, of course, at that time, very few people even proceeded to do a cricothyrotomy or had ever done a cricothyrotomy were familiar with the technique. So we said, do a cricothyrotomy, transition to a neck rescue with whatever technique you're familiar with, whether it was a surgical technique or whether it was a needle technique or whatever. So these were the high points of the guidelines. So if you ask me, then why did we really need the 2025 guidelines? Almost 10 years later, why did we need these new guidelines? So obviously the technology over the last 10 years has evolved. There's been additional evidence and changes in clinical practice in the last decade. In addition to this, there have been previous algorithms that they do not produce guidance on failed SGA insertion, failed face mask insertion, or other strategies commonly used as part of a primary airway plan. So our guidelines and most international guidelines start with a failed intubation. But people would say, look, I'm not using intubation. I'm using suprachoroidal airway device for most of my anesthetic. So what happens when the SGA fails? You only talk about a failed tracheal intubation. So we also got thinking about that. So what if you're using an SGA? Or what if you're using face mask ventilation or any other technique? And the other thing is there was a need for risk evaluation prior to extubation. So as most other guidelines, we called it difficult extubation. Now that's a misnomer. Extubation is never difficult. How can pulling out a tube ever be difficult? So what we really needed to address were what were those at-risk situations where the extubation is at a risk of failing and there's a chance of reintubation. And those were the situations we needed to address. And also over the last 10 years, as you all appreciate, there's been increasing role of ultrasound and also Sugamadex. So we needed to even incorporate this and, think about how we would, put this in, contextualize this with the new guidelines. And therefore we said it is time to revise the guideline. And of course, it had already been 10 years. So Dr. Rakesh already talked about the robust methodology. So we said, let's not just do, the just like a narrative review, do a literature search. And we said, let's have a structured literature search. So what we did is we did the literature review. We formulated PICO questions. We had a systematic literature search, data extraction, and also evidence synthesis. We used PubMed and Scopus, and all papers between January 2000 to 2024 was the period. And 2 reviewers independently screened the titles and abstracts and selected the final list of full text articles. And then we didn't use grade, but the evidence was summarized and recommendations were classified according to the AHA class of recommendation and level of evidence. So we didn't use the classic grade, but we did use some form of grading, and therefore these are guidelines, unlike most documents which call it guidelines, but haven't used any form of grading. So these were the kind of Prisma flowcharts that were created. So there were PICO questions, we had concept tables that were made, and then the search string, and then finally the PICO flowcharts. So this was a very rigorous process through which we went. And this is just to show you what the AHA Association class of recommendation and level of evidence. So this is what we tried to give each of them a class and a level of evidence for whatever recommendations we made. And wherever the evidence wasn't very good, we also did something very unique. We used Delphi methodology. Now, Delphi methodology is used whenever there is, when you don't have robust evidence and there's gray areas. So rather than say you can do this or this, what you could do is you can use consensus among airway experts. So that's the next best thing to do when you don't have evidence for a particular thing. And there are many aspects in airway management, like should you do 2 attempts or should you do 3 attempts? Which technique of cricothyrotomy should you use? So when evidence is absent or weak, the steering committee initiated a Delphi survey process. And this was also very unique to reach consensus among the airway experts. And we used predefined criteria for selection of the experts. And the statements and what we did is we took 75% or more, as the consensus. And we had both multiple choice and Likert scale questions. And we not only looked at consensus, but we did Delphi, robust Delphi process, where we also looked at stability. So the stability between the responses is more important than the consensus that is generated. Just to give an example, for a response in a multiple choice question, if I give A as the first answer in round 1, and then in the second round, I give the answer D, there is no stability between my responses. So the iterative rounds in a Delphi process actually end when stability is achieved between the responses. So it was a really robust process, and we have had a methodologist for this. And then finally, from the statements that achieve consensus, whatever recommendations were drafted for the algorithm, we use these expert consensus statements. So it was a combination of the grading, using the AHA methodology, using the AHA recommendation as well as the Delphi methodology. So you can appreciate what a rigorous process we went through. So this was, and then when we did all this, we said, this is like a lot of work, and we made a separate publication we had on guideline development and the process and the methodology, because it was a huge amount of work to just fit into the adult guidelines. And we also had a separate paper, and all this is in the Indian Journal of Anesthesia in the November issue, on the expert consensus statement. So all the details of what I'm talking to you about, and even if you want to do a Delphi process for some other subject, are very well documented in these two papers from the Indian Journal of Anesthesia. And then, of course, there was the adult guidelines and the other guidelines, but I will be focusing on the AIDAA guidelines for the management of unanticipated difficult airway in adults, and this is under general anesthesia. Now, this is important to understand that we're talking about patients under general anesthesia. We are not talking about awake intubations. We are not talking about emergency airway management when a patient suddenly crashes in any perioperative area, right? This is very specific to anesthesia in adult patients, and you have an unanticipated difficult airway. So this is what the algorithm looks like, and I'm going to with you step by step. And as you can see, a circular image in the middle, it is not the the algorithm like you saw the previous one, if you remember what I showed you, where it just progresses from a failed intubation. Okay, so before I start with talking about the algorithm, I'll just talk about what we generated from the methodology, what recommendations that we made, and I'll also talk about the consensus statements that we generated to the Delphi process. So here, the first one was, does video laryngoscopy improve success rate compared to direct laryngoscopy? So this was an important question. And over the last 10 years, as you know, the evidence has really evolved. So video laryngoscopy improves the success rate of intubation compared to the direct laryngoscopy, and is recommended to be used as a primary device or rescue device. So this was a recommendation, and it was, the strength of recommendation was 1 and level of evidence was A. And I think this is the strongest that we have. I think last 10 years, it's really, really clear now through several meta-analysis that video laryngoscopy is superior to direct laryngoscopy, increases first-pass intubation success, and should be used as a default technique for airway management in the operating room. The next question was, does the use of a bougie or a stellate improve intubation success? And a bougie may be considered to improve intubation success with a Macintosh blade, and the use of a stellate can also be beneficial. So this were both best practice statements, 2A, 2B, and the level of evidence was lower. And then the third question that we asked is, does apneic oxygenation during the intubation reduce the risk of desaturation? So we're using a lot of apneic oxygenation during attempts at intubation, and the recommendation was apneic oxygenation during intubation can benefit and reduce the risk of desaturation. So that is again a best practice statement, and the strength of the recommendation were 2A. So these were the 4 statements that we had for the adult guidelines, where we use the AHA classification to give the grade. But then there were many areas where the evidence was weak, and we had to use the Delphi process, as I mentioned. And for this, we had the expert consensus statement, and you can see on the right side column, you can see the consensus that was generated. So the one question was, should neuromuscular blockade be administered when there's difficulty in mask ventilation is encountered? So this has always been something that's kind of challenging dogma, and throughout we've been told that don't give a muscle relaxation if you can't ventilate. And here the expert consensus statement was that neuromuscular blockade should be administered to improve mask ventilation when difficulty in mask ventilation is encountered in adult patients. So this has been a paradigm shift in the way we look at airway management, and you actually give the muscle relaxant when you face difficulty, because this can actually make your mask ventilation easier and improve the chance of success. At what oxygen saturation? Now, this was tricky. Should laryngoscopy be re-attempted following a failed intubation in adult? And this is the cutoff where was 95%. And some might wonder why not a lower cutoff? So if you look at the oxygen dissociation curve and you see the in the saturation, that's so when you're seeing a saturation of 95, it's probably much lower. So we also kept that into consideration. So big emphasis on reoxygenating before you go on to the next laryngoscopic attempts, which no guidelines. They tell you 3 attempts or they tell you 2 attempts, but they don't talk about reoxygenating before attempts. And what is the maximum number of attempts of tracheal intubation? Now, this was tricky. So should you keep it 2 attempts, 3 attempts, 4 attempts? So the consensus was for a maximum 3 attempts at tracheal intubation that should be permitted to limit airway management related complications. And as you see, you can have your consensus of 87%. And then the similar thing for supraglottic airway, how many attempts? And again, it was a maximum of 3 attempts at supraglottic airway insertion that should be permitted. And this had 100% consensus. And which cricothyrotomy technique should be performed when there is complete ventilation failure? Now, as I mentioned in our previous guideline, we said use whatever technique that you're familiar with, but now there is growing evidence that the surgical cricothyrotomy is superior to the needle and even the use of commercial sets. And the consensus, almost 91%, was a surgical cricothyrotomy should be performed when there is complete ventilation failure. So these were the consensus statements that we used, derived from the Delphi methodology, along with the grades, the recommendations that we had from the HA grading that we used to make the algorithm. So this is what the adult algorithm looks like, and I'll just go through it now in brief with you. So this is patients who have a difficult airway under general anesthesia. So you pre-oxygenated the patient, you induce anesthesia, and you have some primary airway management plan. And as I mentioned earlier, we are not restricted to tracheal intubation. You could be using TIVA, you could be using a supraglottic airway device, you could be using any technique, just doing the anesthetic on face mask, whatever is your primary airway plan, okay? Now, if you're successful and you continue as planned, okay? So this is the statement. So primary airway plan, as I mentioned, could be any of this. It could just be even nasal cannula, or you're just using an airway adjunct in combination. It could be spontaneous ventilation or could be controlled ventilation, whatever is your airway management plan. Now, if you're successful, very important to check that you have, especially when you've intubated or you have supraglottic airway device, that you have sustained exhaled carbon dioxide. And this was from our PUMA recommendations from the guidelines that were published to prevent a missed esophageal intubation. And I really urge you to read this paper. And this is published in Anesthesia in 2022. And it's really important that if you've intubated a patient, you shouldn't just look at one trace of end-tidal CO2. You should look for consistent waveform capnography without any decline. And this is really important. And you should have no declines. For instance, you could have something like this where you can see your initial trace, capnography trace, and there is decline. So you never comment whether the tube is in or not by just looking at one or two waveforms, because, especially when you have a difficult intubation, and even if your tube is in the esophagus, a lot of air has gone to the stomach. And when you start to ventilate, you will probably get a lot of CO2, but after some time, it will decline and it will flatten. So this graphic is very important from this paper, and we emphasize the use of capnography. Now, you pre-oxygenate, induce anesthesia, and if you're not successful, for example, if you're not able to mask ventilate, or you're not able to insert your supraglottic airway device, or you're not able to intubate the patient, whatever way by which you're not able to ventilate the patient, at the first difficulty, what's most important, of course, as we always say, is call for help. So right along our algorithm, the vertical bar for calling for help is always there. If you've forgotten to call for help earlier, you call for help later. Most important, as you're trying to secure the airway, the depth of anesthesia is important. So maintain the depth of anesthesia throughout and deliver nasal oxygen. So we've given huge emphasis on continuing nasal oxygen securing an airway. So these 3 vertical bars, as you see, are the real 3 pillars, and they go through the entire algorithm, emphasizing that throughout you should keep it in mind that give oxygen, give oxygen, give oxygen, call for help if you haven't, and maintain depth of anesthesia. So whatever your primary airway plan is, if you're unsuccessful, okay, we have a new code. So there was consensus among the AIDAA members that we should use code D, difficult airway. Code D should be used as the code to communicate. So, you have code blue, specifically that this is an airway problem, right? I don't want just anyone coming to help me. I want someone who can assist me, who is an airway expert, to come there and help me. So the code that, the consensus was for using code D as a code that you would use as a, a kind of call in any hospital setting, and to promote this so that people know that it is specifically not just calling for help, but calling for help for a difficult airway situation. So let's come to the situation where you've been unsuccessful. And unlike the vertical kind of, boxes that we had previously, what we have this kind of circle that you enter, and you enter this orange box. So what we say is use one of the following devices, and there's no hierarchy. You can start with any of the devices, okay? So for instance, if I fail tracheal intubation, I might put you go to a supraglottic airway device, or I might go to a face mask, or I might try tracheal intubation again. So if you see, there are bidirectional arrows, which means that you keep interchanging between these devices, okay? So there's no hierarchy. You start with any device, and if you're unsuccessful, you can change over to another device, and you don't proceed from one to another. You can go in any direction. As I mentioned, it's bidirectional. Now, what's above this line is always consider optimizing position, ensuring neuromuscular blockade, changing your tools, your technique, or even your operator. And this is very important if you want to ensure success with your procedure, isn't it? Because I don't want to do the same thing again and again and again, same size tube, same direct laryngoscopy is used all the time. So I need to change to doing something different. And if you see with the tracheal tube, what we have here, we have the video laryngoscope. So what we've talked about is whatever your primary airway plan, when you move on to tracheal intubation, when you move into the orange box, you must do it with the video laryngoscope. And this is again based on the evidence-based recommendations that we had, already done prior to making the guidelines, right? So you have to do something in your next attempt to to increase success, whether it's positioning or neuromuscular blockade, and keep interchanging between the devices. Now, it's really important that you can't do this endlessly. You must limit the attempts. Maximum 3 failed attempts with each device. Now note, this is very important. 3 failed attempts. Okay, it is not 3 attempts, but 3 failed attempts. And the reason for this is that when people say, if you look at the vortex approach, they talk about 3, 3, 3. But you can never put a number to mask ventilation, because mask ventilation is a non-invasive procedure. I might do mask ventilation 10 times. I might keep reoxygenating between attempts, attempts at putting a supraglottic airway device or whatever. So how can you put a limit on a mask ventilation? Nevertheless, you have to have a strategy to exit this orange box. So you have to have even some limit on the mask ventilation. So rather than say 3 attempts at failed ventilation with a mask, we said 3 failed attempts. So if you fail mask ventilation 3 times, then that is the upper limit. Or you fail intubation, or you fail a supraglottic airway device. And most importantly, as I mentioned, we said that tracheal intubation should be attempted only if the saturation is more than or equal to 95. And I've already explained the reason for this. And most importantly, throughout, keep track of time and the saturation. What happens is when you're in all this mess, people tend to forget how much time has lapsed. If you see the Ellen Bromley case, people lost complete sight of how much time had lapsed between the procedure, and someone should also keep track of the saturation. So keep interchanging between these till you achieve success with the ventilation, right? And then if you are successful with this, then you move to the right side. As you see, the orange, you move from red to orange, and then you move towards green. So if you're successful, you use one of these devices without any hierarchy, and you're successful, then if it is a tube you're successful with, of course, you have to confirm tracheal placement with a capnography. And if it's a mask or a supraglottic airway device, then you could consider either awakening the patient, or if you think the procedure is safe to continue, say it's a small breast surgery or something, I can do it with a supraglottic airway device, then you can continue the procedure if it is considered safe. And if you are continuing with the supraglottic airway device, you can consider intubation through the device. But remember, never take out the device when you establish ventilation. If you decide to intubate through the supraglottic airway device, you should use a flexible bronchoscope, and you must have someone with the expertise to intubate through a supraglottic airway device. And the last option is a tracheostomy. So even the tracheostomy, though someone might think it's quite absurd, in a very remote setting, where say I have to proceed with a head and neck case and I have to do this surgery, even a tracheostomy is a safe option rather than losing the airway. Of course, it's an extreme option, but even that is one of the options when you can ventilate this patient and you still need to proceed with the surgery. So this is provided you are successful after you've been interchanging through the 3 devices, right? So one of these options should be considered. Then we go back to the algorithm, and you may be in a situation where you have inability to ventilate when you've used these 3 lifelines that you have, the tracheal tube, the supraglottic airway device, or the face mask, despite your best attempt, okay? And also giving complete neuromuscular blockade. Despite that, if you are unable to ventilate, what we reach a situation what we call complete ventilation failure. And when we reach this situation that you cannot ventilate with either of the 3 lifelines, despite your best attempt, we say call for additional help. And as I mentioned, this calling for additional help is not only a helping hand, but it is also for somebody who can come and think clearly and who's not part of this mess. And throughout, you have to still continue your efforts at rescuing and face mask ventilation. And here you can see we have a pictorial image, and we felt this was very important because we want people to focus that stop accessing the airway from above and transition into neck rescue and think about doing an emergency surgical cricothyrotomy. As I mentioned, that was the consensus that we had, that surgical cricothyrotomy should be the preferred technique. And as you see here, we don't say that you don't do the other techniques. We should prefer surgical cricothyrotomy. However, if you are trained to do a needle cricothyrotomy or using any of the commercial tricks that could also be used, but we gave a priority to the surgical cricothyrotomy, which was not the case in the previous guidelines. Now, I just want to spend a minute explaining this complete ventilation failure. Now, why we use this term complete ventilation failure? Now, if you see other guidelines, they use cannot intubate, cannot oxygenate, CAICO, and FONA, or they use cannot intubate, cannot ventilate, different terminologies they use. And I'll tell you why this is an appropriate terminology. So if you see, when you have failure to ventilate the lungs, despite the best effort, like you saw, using the 3 devices. So there are different stages. So you have failed tracheal intubation, failed supraortic airway device, failed face mask ventilation. So you have failure to ventilate the lungs. And this is the first place where we say, the first step where we say declare complete ventilation failure. Another step could be when you have failure to oxygenate. Okay, so you could go lower down in the chain from 100% saturation to you're going to cardiac arrest and hypoxic brain damage. And here you could declare failure to oxygenate, or you could declare failure to oxygenate even lower down when your patient starts to dehydrate. So it's important to remember that ventilation failure precedes oxygenation failure, right? When you cannot ventilate a patient, this patient will desaturate. Now, how long this patient will take to desaturate depends upon how well you have pre-oxygenated the patient, what is the physiological reserve of the patient, have you used apneic oxygenation or not. But it is inevitable that when you cannot ventilate a patient, eventually he will desaturate. So isn't it better to have step 1 as a trigger to proceed to do the emergency cricothyrotomy when the saturation is still 100% or still preserved, and your hands are not trembling listening to the tone of the pulse oximeter and the patient desaturating. So when we say, what we say is ventilation failure precedes oxygenation failure, and that should be your trigger to perform an emergency cricothyrotomy when you declare complete ventilation failure and not when hypoxia has set in. And that is why we feel the terminology cannot intubate, cannot oxygenate may be inappropriate. Also, in the era of apneic oxygenation is not very well understood. We did a survey and we tried to find out what people understood by oxygenation. To some people, it meant that they could not ventilate. To some people, it meant that the patient is desaturating. So in the era of apneic oxygenation, I may be able to preserve the oxygenation for a very long time. But as I mentioned earlier, it's important to remember that once you cannot, you fail ventilation, failure to oxygenation will be inevitable and the patient will desaturate. Coming to the technique, what we've recommended is the surgical cricothyrotomy, and a very simple technique. Like you have the scalpel bougie technique that is recommended by the DAS. We have the stab, twist, bougie tube, and we teach this extensively in our workshops. And it's a very, very simple technique where you use just a scalpel, a bougie, and a 6-number endotracheal tube. And another reason why we recommended the surgical cricothyrotomy is also looking at the diversity in the airway management practices across the continent in different resource settings. Definitely a scalpel, a bougie, and a 6-number tube will be available universally. You may have a needle and a syringe, but a jet ventilation may not be available, and commercial kits may not be available. So what is important is we need to train more and more people to do this surgical cricothyrotomy. And the last part of the algorithm is a post-procedure plan. And this is also very important when you've had an unanticipated difficult airway. The further airway management plan is very important. We need to assess the airway further. The airway might deteriorate. You need to monitor this patient. If there's airway edema, you treat it, and if it is suspected, because the patient's airway might deteriorate further, and monitor for complication. And most important, whenever you've had an unanticipated difficult airway, important to counsel the patient if possible and the family, and also document and tell them that you had a difficult airway, so that the next time they go for an anesthetic, they can tell their anesthesiologist or even their GP that this was the situation that I faced. So a previous history of a difficult airway is the most important history, especially when you're proceeding with a new anesthetic. So this is what the AIDAA adult algorithm looks like. And as you can see, I mentioned about the 3 vertical bars, and there's this emphasis on calling for help at any time point if you've missed it, maintaining depth and delivering oxygen throughout. The pictorial representation, and we have the orange box, going further down as to the red zone, or moving to the green zone once you've established ventilation. Here is the post-procedure plan. So we also have the obstetric guidelines and the pediatric guidelines, and very, very nice 3-limb extubation guidelines will be discussed at different different webinars. So what's new in the 25 guidelines? As I mentioned, robust methodology. I've emphasized that we used the AHA for level of evidence and our recommendations. And wherever there wasn't good evidence, we used a very robust Delphi process. Code D is new, and this has been proposed as a hospital emergency code. So in your respective settings, when you say code D, popularize this term so we get help, not just any help coming, but someone who has expertise in airway management. And guidance for a failed. So we've not only talked about failed intubation. You could be at any starting point. You could be a failed SGA, mask, ventilation, other strategies. You could be using TIVA, you could be using nasal prongs, hypnosis, whatever strategy fails when you're unable to ventilate the patients, and either spontaneous or rebreathing or controlled mechanical ventilation, whatever the situation, you can enter the orange box and interchange between the devices. And we've moved away, most importantly, which no other guideline in the world has done, we've moved away from the linear approach to this circular pattern with emphasis on interchangeability between the three devices. And there's no hierarchy that you have to start with the tube or you have to. So, whenever you have an unanticipated difficult airway, remember, I have 3 lifelines and I have to keep changing between these 3 lifelines until I achieve successful ventilation. And we've also collaborated with the pediatric and obstetric societies. And most importantly, our previous emphasis that we had on pre-oxygenation, insistence on using waveform capnography and 6 traces. We were one of the first guidelines to not only specify waveform capnography, but to say that you need to look at 6 to 7 traces of consistent waveform capnography, which even the other guidelines did not do. And the new terminology, complete ventilation failure as a trigger for cricothyrotomy, has also been further emphasized in these guidelines. So I'll leave you here with just the QR code for the guidelines, and these are available as a free download in the November IJ issue. I stop sharing and I'm happy to take questions and proceed with further discussion. Thank you very much.
Thank you so much, ma'am. And over to the chairperson for the day.
So, good evening. I must congratulate AIDAA for coming up with such a beautiful guidelines, and Dr. Sheila for summarizing it so beautifully in such a short span of time. So, there are certain things I like about the guideline, but first I would like to ask a couple of queries I have with Dr. Sheila. That when you say that para-oxygenation has to be done with nasal cannula, so not everyone at all times would have the high-flow nasal oxygenation. So the regular nasal cannula, what should be the flow that we should keep?
Yeah, so this is a very, very important question. You're absolutely right. And it is not whether you have it or not have it. Like, for instance, we have hyponasal oxygen, but I'm not going to open that full set, okay, because I will think about the cost for just those 3 or 4 minutes, unless it's a very difficult airway and I'm, kind of thinking that, 80% this might fail, right? So simple nasal cannula, as you mentioned, but the flow is very important. When we talk about, and this technique is called no desat, nasal oxygen during efforts at securing a tube, and the flow should be at least 15 liters. So our flow meter doesn't go up to 15 liters, but if you crank it up completely, it gives a much higher flow. So we encourage not only during a difficult airway situation, but any airway, we say that you should encourage people to give nasal oxygen during attempts at securing a tube, because this can prolong your safe apnea time from up to 12 to 15 minutes, beyond the 8 minutes that you will get if you do pre-oxygenation well for 3 minutes. So this should be part of your regular practice, especially when you think that you may, this may be a difficult airway. It is a good idea to use the nasal apneic oxygenation with the simple cannula. That's what we practice.
Thank you. And another one, that when we're talking of pre-oxygenation, what I commonly observe amongst my postgraduates is that they will not apply the masks to the face. There will be a gap between the skin and the face. So maybe at times it is because the patients are not comfortable. So can you please exactly describe how to do pre-oxygenation correctly?
So, you are absolutely right. And I face this in the operating room every day because people are so busy keeping everything ready for intubation that pre-oxygenation is given the least priority. And actually, that's the most important. And what people do is they just hurriedly hold the mask on the face and they rush to induce without giving adequate time for pre-oxygenation. And like you rightly said, it's about when they're worried about holding the mask too tight because they feel the patient will be uncomfortable. But no one talks to the patient. Okay, if you tell the patient, that I am giving you oxygen. I don't want it to leak. So you will feel this little pressure. Whoever says that to a patient. So I think it's important to tell the patient because the patient is awake and not just press it very firmly. But at the same time, you won't want a leak too much because it's going to be ineffective. The other thing is that we talk about 3 minutes of pre-oxygenation. How many of them are giving 3 minutes of pre-oxygenation? And the importance of that is also there. And, our modern machine have end-tidal O2. Everybody talks about 3 minutes of pre-oxygenation, but nobody is looking at the end-tidal O2. So AIDA has given the recommendation for the pre-oxygenation that we should target more than 90%. People are, inducing the patient when it's just 60% or 50%. So fill the FRC with oxygen. And when it is more than 90%, that is the time that you say, okay, now we're ready to induce. So you have very objective endpoints for pre-oxygenation. And we should use that with the modern anesthesia machine because we have gas monitoring. So rather than just say 3 minutes, we should look at the end-tidal oxygen, and this is for the trainees. And we know the consumption is 250 ml per minute. So if you're just going to do 1 minute, if you're just going to pre-oxygenate or not pre-oxygenate and give just 21% oxygen, this patient may desaturate in 1 minute. Whereas if you've given, say if your reserves are, 250 and 2,500 and you're consuming 250, you will have at least 5 to 7 minutes before the patient desaturates. So thank you for bringing that up. And I think that pre-oxygenation part is something we take very lightly and we're in a big hurry to induce the patient and we don't spend time to do that. Thank you for asking that question, ma'am.
Thank you so much. Rakesh, I think there's something in the chat box you can.
Yes, ma'am. Yeah, there are a couple of questions, ma'am. You can take up, ma'am.
Let Shaila take it up. Yeah.
Dr. Nikki,
She's the
ma'am.
more appropriate person. Shaila or Nikki madam can take them.
Yeah.
Ma'am,
No, before I take up the question in the chat box, so I want to thank you, Sheila, for an excellent lecture and your new guidelines. And I really appreciate the end-tidal O2 monitoring, which you have given, I think, is a 91%, and the end-tidal nitrogen, we are not using these normally. So if that is 4% and this is 91%, I think this also needs to be highlighted, and you very nicely explained the FRC concept of that. So I think that is really good. The only concern is, will the patient tolerate 15 liters of oxygen? And another issue is sometimes we don't have two sources of oxygen, like in the emergency. So now we have the central pipeline, oxygen, and we have just one source. So to have a second source, you either need the cylinder or you need to, take it from the neighboring bed. That becomes a little challenging, which I try and emphasize, because we are doing a lot of intubations in the emergency department also, and they can be challenging at times. But this concept is really, really good, and I think we should emphasize on this end-tidal.
Can I ask something? In case you don't, like Madam said, in the emergency department, you at times might not have the end-tidal oxygen, but you would definitely have the capnograph. So can a capnograph, like when you are pre-oxygenating, seeing a capnograph trace, help in any way? Because in the emergency department, yeah, that would be a challenge.
I just love this discussion. It's beautiful. These are all the points that are very close to my heart. So during COVID, we emphasize this. Usually we look at the capnography trace when an intubated patient. But for SG and even the mask ventilation, when your patient is spontaneously breathing, when you're holding the mask adequately, you will see a good capnography trace. Okay. So this is also something very important to monitor. And we shouldn't think about capnography only in the context of the tracheal intubation. And Nikki, madam, thank you for bringing up that, end-tidal O2 more than 90, and we keep the end-tidal N2 less than 4%. But also, you may not have gas monitoring in all areas, especially outside the operation, in the ICU, in the emergency department. So a good 3 minutes of pre-oxygenation should be And when you have a leak in the mask or you have a Riles tube or something like that, then we should pre-oxygenate for at least 5 minutes. So that is what is, recommended. And about
Yeah.
the flows, when we're using high flow nasal oxygen, we usually start with 30 liters. So 50 liters is really not much. Anything more than 30 liters, and that's dry oxygen, and that causes a lot of discomfort and can also cause, some bleeding. So 15 liters is really well tolerated. So it's something simple, cheap, and especially when you have a difficult airway, it's very underutilized. People should start, we give about 20 degrees propped up position, and we give the nasal oxygen during attempts at securing a tube. So you've removed your mask. Yes, but the challenge is you do need another source of oxygen, and that may be not available at all times. You may need even a cylinder and, give oxygen like that. Yeah.
So, just another challenge which I'm facing. Sorry to divert the discussion a bit, but I know the guidelines are for general anesthesia in adult patients, right? Unanticipated difficult airway. But in the emergency too, we are anesthetizing the patient, giving them etomidate and the rocuronium and whatever to intubate. Now, you will be surprised. My faculty is all specialized in emergency medicine. Somewhere over there, we have to introduce ETCO2. They had not used ETCO2 even in big hospitals of Delhi, where they have done their post graduation from. And I have had to really rub in the importance of ETCO2 and bring it into my ED. And slowly, slowly, they're getting into the concept of what this is and what the importance of this is. So our guidelines are really good for all anesthesiologists, but somewhere I think we need to push them into the emergency physician
Thanks for
curriculum too.
So we have the credit of coming up with the first guideline for tracheal intubation in the ICU, and huge emphasis on capnography. And if you see the national audit project that was done 10 years ago, showed that looked at perioperative complications with airway management. They looked at the subgroup of patients in the intensive care unit, and they found that not using a capnography actually resulted in 80% of morbidity and mortality.
Yeah, definitely. I don't need any convincing, and I'm too on. But I was shocked to know from my emergency physicians that in their hospitals, big hospitals where they've done it, they haven't used ETCO2. They have not even been told about it, which is so surprising.
Absolutely. And this is not unique to India. We had done the Intube study, which is a global study looking at airway management practices in critically ill patients, and only 1 in 4 airway operators were using capnography. So in the operating room, we use extensively capnography, but outside the operating room, in the emergency department and in the ICU world, this is not practiced. And because they are, I would not, I mean, they don't, are not aware of it sometimes. I would give them a little bit, give them this thing, and they don't understand the importance of it at times, and sometimes they feel it's not required. But it is,
the hospitals, the big medical colleges where the anesthesiologists are looking after intensive care, we are always having ETCO2 monitoring. But the other hospitals, they don't have ETCO2 even in the critical care units, and they have patients on ventilators. So this was really shocking for me to know, and I think somewhere we need to push it in, because you've been president of the Critical Care Association, so somewhere that needs to be emphasized also.
And we as anesthesiologists, it's our duty to make the intensivists and the emergency department people, familiar, emphasize the importance of this. But having said that, it's not only in these regions. These 2 deaths that occurred in the UK and also the one in Australia that occurred, which had, because of which Puma had to make this emergency guideline for preventing missed esophageal intubation, happened in the hands of senior anesthesiologists. So we always think missed esophageal intubation, that can never happen to us. That can never happen in India. Or, I have people saying this has never happened in India, that you miss an esophageal intubation. That's not true. That's not true. That patient, they presume the patient had bronchospasm, and the patient, and this resulted in death. And this is something we had to very urgently come out with the Puma guidelines for the missed, how to look at the capnography trace. And most of us as anesthesiologists, we look at the capnograph, one trace, and we say, okay, tube is in.
Yeah.
The response that is also.
No, it's very important. And the 6 graphs that you have emphasized earlier, we used to say 4 or 5, but now we've come out with the 6 graphs. That is very, very important also to.
I also want to give some credit to the Indian guidelines of 2016. All guidelines said use waveform capnography. Indian guidelines was the first one to say use 6 consistent cases in 2016.
True.
And when Puma made the guidelines, they used it from the Indian guidelines, because we had already said that it is not just waveform capnography, but a number of waves and the consistent waveform. That is important.
We are very proud of all of you, and you've done a great job
No,
with these
ma'am,
guidelines.
If you're talking of the supplemental oxygenation, there is one terminology you have given as periox during extubation. So, what should be the way of oxygenating and the flows to do this periox? Just
I
for the
will ask Dr. Rakesh Garg to answer
We
this
will have
question.
a separate guidelines on extubation. So little suspense may be there for 2 weeks.
Okay.
Yeah.
And
We always focus on peri-intubation oxygenation, but oxygenation post-extubation is also important. So we'll leave that for the next webinar. Yeah.
And I
Hello.
assure you that extubation guidelines and certain additional components which AIDA has come up are really very useful, because we take it for granted that extubation will be safe for all, but we are stuck up. So I think that session will also be very good. Just stay tuned to Cuisinar, and we will come with those questions, ma'am.
Yes.
So I think
Hello.
Dr. Javed wants to comment. Yes, Dr. Javed.
Good evening, Dr. Sheila. Let us accept my heartfelt appreciation to you and Dr. Amit, Dr. Rakesh, and all the members who are very instrumental in contributing to these guidelines. Really, a collective efforts made so much of precision and safety in the field of anesthesia. The one question that you have mentioned in the guidelines about this video laryngoscope, that it didn't involve any positioning. But personally, I feel if it is done in the proper ramp position or sniffing position, that will help much more than what it is. So can you clear up on that point?
Yeah, so specifically, you don't always need to position the patient, but of course, if you have obese patients and you have, obstetric patients, you can use ramping and align the axis and make this thing. But that's one of the advantages actually of the video laryngoscopy, because you're dependent on the camera and not necessarily the position, unlike in direct laryngoscopy. But we have given importance on positioning for other aspects like pre-oxygenation, etc., where we talk about giving at least a 20-degree
Yes,
elevation.
that I have to
People-
appreciate. 20-degree,
Operating room,
when I
yes.
started using it, I find it very, very significant and very useful.
And
That's
this is
hats off to you for that.
in patients with normal, which have some lung pathology, because the posterior portions of the lung become more dependent, and those, are prone to collapse and atelectasis. So that's why, giving this propped up position for the pre-oxygenation and even tracheal intubation with a 20-degree head elevation is possible. And we should encourage this in our operating rooms, because every time we keep the patient absolutely flat. So we should move away from that, especially during pre-oxygenation.
That's
And
very useful,
what
very
I would
useful.
make is everybody saying your guidelines, your guidelines. Please, this is our guidelines, okay? This was just initiated by the society, but this is guidelines for all of us. It's our national guidelines. And I'm really proud that during the World Airway Management meeting, when the DAS guidelines were released, the AIDA guideline was given a presentation at the same time as the DAS guideline. And that was a huge moment for India, because we always in India, we say, oh, we won't look at Indian guidelines. We want to follow DAS guideline. We want to follow ASA guidelines. And we, look down as if Indian guidelines are a cut, copy, paste job. But to have the platform to present our guidelines at the same time as the release of the DAS guideline was a huge moment, a very proud moment, I would say, for India. Not just for AIDA, but the world is recognizing that we are intelligent people and we are coming up with good guidelines, and it's not just aping the West and taking ideas from them. And we are coming up with very unique, innovative ways by which airway can be secured safely.
And one more thing, that you was demolished as hierarchy. Intubation or supraglottic devices or face
that's
mass ventilation.
very
That is
important.
that is very important. That is one.
So, this concept comes, if you've seen the vortex approach, you must have seen the vortex. So this concept of not having a hierarchy comes from there, and we've acknowledged that in the guidelines. That you don't start from, it used to always be, okay, tube failed, then you go to supraglottic, then you go to this thing. But here you might start with the supraglottic and that has failed. Then what do you go to? So we say that, in a 2D image, it doesn't look like there's no hierarchy. So we have to specify there is no hierarchy. So you have to interchange. So, this concept in your mind that we have to have, that whatever technique you're using, you have 3 lifelines. Keep changing from one to the other. Don't go on and do it. And maximum 3 attempts, 3 failed attempts at each. If we have this concept in our mind, because people have fixation. I remember when I used to be a trainee, the seniors used to go on and on and on and on with laryngoscopy, and that time we didn't know, we didn't understand this. But if we can even think like this, that you have 3 lifelines, keep interchanging. never mind which one you use, but try to, your goal is to achieve successful ventilation with whichever device, and make sure you don't have more than 3 failed attempts at each. So which means 3, 3, 3, which actually means 9, like you could go maximum 3 with supraglottic, 3 with the tracheal intubation, many times with the mask, but 3 failed with mask should make you exit.
Thank you
I
so
think
much.
there are a
Thank
lot
you.
of queries
There
in
are
the
some
queue of
questions in the
equipment.
chat.
Yes.
So if chairperson will allow,
Yeah.
or Dr. Amit will allow, we can
Yeah,
take the
yeah.
questions. If there are no more
Yes,
questions
yes,
from the
sir.
chairpersons.
No, there are so many questions, in fact.
Yeah,
So the first is from Dr. Ruchi.
Ruchi, yeah.
Thank you really for the simplified lecture. If primary airway management plan is intubation and if patient desaturate drastically straight away during the mask ventilation itself, okay, with relaxation and adjuncts, it is hard decision not to take any attempt of laryngoscopy even once and go for tricho. So she said that you decided to intubate, you do mask ventilation, and then saturation starts falling for some reason.
So this is exactly what the the circle is about. So I might want to immediately put in a supraglottic airway device in that. It is only for tracheal intubation that we say between attempts, you make sure the saturation is more than 95. But if you're mask ventilating or you have a supraglottic airway device, sometimes you're not able to mask ventilate. It's a very difficult mask ventilation. I'll put in a supraglottic airway device and I may be able to ventilate better, maybe with a heavy jaw or whatever. But we're just saying that when it is tracheal intubation, make sure you re-oxygenate, because when say Daz said 3 attempts, people understand is okay, 1 attempt is over, I go for next attempt, saturation is 80, but you're going for second attempt without re-oxygenating, third attempt. So the meaning is not that you have 3 attempts so you can go on to 3 attempts. That emphasis on re-oxygenating and not proceeding to the next attempt of tracheal intubation unless the saturation comes up to you re-oxygenate the patient is something we did in the 2016 guideline, and I think that's really important for airway operators to understand that part, because the ventilation is more important. And I always say that not intubating will not kill the patient, not ventilating will. So keep the patient oxygenated at all times.
Yeah, can I add something here? So Ruchi, much before these guidelines came, I'm talking about the 1990s maybe, we had this very obese OSA person for an ENT procedure. The surgeon was going on leave the next day, wanted to do this as a semi-emergency, and we had the same situation. We induced him, and we could not mass ventilate. Saturation started falling. The LMA had just come in, and we had it on a trolley, and I just inserted the LMA, and we could oxygenate, ventilate, and get the surgery done. So that it's a real lifesaver. So what Dr. Sheila has said, I second that very strongly. You don't have to think of laryngoscopy at that time. So this circle that they have made between mass ventilation, supraglottic, and intubation, you have to choose at that stage what is best. So if you can't mass ventilate and oxygenate, try the supraglottic. And that is also an area.
Just one more point which I missed saying, that we do have this in the text. And again, I've just shown you the algorithm. You really have to read the text along with it. Now, if you're in a situation where the patient just crashes, bradycardic, this thing, you can bypass this and directly go to a surgical cryotherectomy. You don't need to do it when the patient just desaturated, you can put in supraglottic. But we also say that you can completely bypass this and directly proceed if you have that kind of absolute dire situation. So there is a provision for that as well.
Okay.
That is
Next
provided we have the equipment available at that very moment.
Yeah,
And
so
that
madam,
is another issue.
thing about the universal cryotherectomy. Whichever airway setting where you're giving general anesthesia, you will have a scalpel, you will have a 6 number 2, and you will.
Yes.
So this is why we have to train more and more people to do this. The thing is that as anesthesiologists, we are very comfortable with needle because we do a lot of sending technique procedures. So put in a needle, but people think I can put in a needle very easily. But you need jet ventilation, no? What are you going to do with the needle?
Absolutely.
So
That's
you
not
need
always
jet
available.
ventilation. That may not be available. So putting in a needle is of no help. And then, the cannula can kink, etc. So this stab twist, this technique that we have is really so simple to do. And we have very good pictorial representation and videos as well. And this is something that we should train people to do in our setting, because this is not something that you can learn on the patient. And every anesthesiologist should be trained to do it. And all the equipment is universally available.
Okay. Dr. Vibhavri Nayak has asked a question that when should nasal cannula be applied? Is it advocated to put on only during ventilation or even during mask ventilation? So should it be applied right when you start the pre-oxygenation and then mask ventilation and while you are attending. So
where we use a lot of apneic oxygenation, we use it a lot for direct DLs and ML scopies, DL scopies, which these ENT surgeons do. And, we actually put the cannula, we keep it on the neck, So then when we're face mask ventilating and we have given the induction agent, we've given the relaxant, we mask ventilate and we remove the mask and we're very quickly putting the nasal cannula. So we don't even apply it over the head. We have it absolutely ready here on the chin, just below the chin, and we immediately connect it and put 15 liters on. So during attempts at securing a tube or any procedure when there's apnea, it should, you should use a nasal cannula because, there's oral instrumentation or, your mask is removed. So nasal cannula is something that you can use, which is very simple and cheap to apply and very underutilized. So our procedures, the surgeons take about 10 to 12 minutes, 15 minutes, and this really prolongs. We have 100% saturation even when the procedure is over. Otherwise, you'll have maybe after 8 minutes, you'll have the patient starts to desaturate. So you're prolonging your apnea time to 12 to 15 minutes. So this, for these procedures, it's really very useful. But now we routinely recommend it for all, all our anesthesia routine intubations as well.
Doctor, thank you.
Sorry, Dr. Amit, if you remember in the AIDAA conference in Delhi, one of our speakers had said he hangs one plastic bag with a scalpel, a bougie, and a 6-number tracheostomy tube on every anesthesia machine for this situation. So he said that is how we started the surgical cricothyrotomy. This is like, okay, way back. Yeah, sorry.
Thank you, Nikki madam. So Dr. Srivas has asked about video laryngoscopy. Since we have already recommended that video laryngoscopy should be, if you have device and if you have expertise. So there are two things he has asked. So is there any evidence that favors the blade, the hyperangulated blade over the Macintosh blade? And what if you don't have hyperangulated blade and you have only Macintosh blade? And second thing he has asked is how to, because many times we have a device, but we do not have experience or expertise.
Okay, so I want to make this thing about video laryngoscopy. I want to make a statement. So everybody is very enamored by tools like ultrasound. Everyone's very fascinated with video laryngoscopy. Remember, with video laryngoscopy, the challenge is not in getting the view. The challenge is in delivering the view. Right? So, and that is why when video laryngoscopy first came, I'm sure those who are experienced airway operators were saying, "Ye kya hai? This is a tool to make tracheal intubation difficult." They would just throw the video laryngoscopy over, put difficult DL and start intubating the patient. So the challenge with video laryngoscopy, you have a camera there. Of course, you'll get the view. Of course, you'll get a CL1 view. The challenge is in delivering the tube, and that needs training. That needs training. You need to use a stillet with a tube. With a Mac blade plus minus, but with a D blade 100%, because you're getting that CL1 view, but your tube is not going in the same axis as the line of sight as with direct laryngoscopy. So even if it's an anterior larynx, you're seeing a CL1 tube, and you see this typical thing, or your tube slipping down. Nice CL1 view, but your tube is not going in that direction. And then even putting the stillet in the tube, the way that it is used, and I see this universally happening, people don't do it correctly. I really urge you to read the guidelines because every part of airway management has been explained very beautifully, So the stillet has to be put in the tube and it has to be pre-shaped as a J shape or a hockey stick. People just put the stillet in and keep the same curvature. The idea of putting a stillet in the tube is to deliver the tip more anteriorly. So it has to be pre-shaped when you use a stillet. Otherwise, it doesn't serve the purpose. So how are you going to deliver the tube is very not getting the view, and that needs training, and that's a reason why people didn't see as much success. To the question, there has been a head-on comparison with the D blade and direct laryngoscope and showing superiority of the D blade. But the question is, I love the D blade. I try to use the D blade all the time. Even when you have a difficult airway and you're using a video laryngoscope, try switching from the Mac blade to the D blade. Say if you're using maybe just a Karl Storz, I'm just giving a name. Try switching and you will see that 60-degree angulation. You'll see such a wonderful view. The view and the, is so much superior. So it really makes your intubation much easier and increases first pass intubation success. But the question really is, how many % of these intubations are really that difficult? Okay, so it may be a 2 or 3%. So you're going to put this bulky device inside for all your routine intubations for those 1 or 2%. So I would rather use a Mac blade, and if I face that difficulty, then switch over to the D blade rather than use it routinely. So if you're really experienced with using a D blade, I would use it routinely. But otherwise, I would not recommend it for routine practice unless you have a lot of practice with it. because it will just increase your time to intubation. You'll have to use a stillet all the time. So, 95% of your intubations will be straightforward. So I like to use the MAC plate, and as a direct laryngoscopy initially for training. So I see the screen but not the trainee, and then do the intubation. So you learn both techniques, how to do direct laryngoscopy using the VL as well as using video laryngoscopy by later looking at the
So I just want to add for Sai, and Sheila, though you have recommended a stillet for VLs, so when we started with the VLs, we were using a bougie. You put that in and then reload the tube over it, because the same issue of delivery. So Sai, I would like to say, first be familiar with the VL that you've got and start using the Mac VL blade for normal airways, and for the airways which are not difficult, so that you get used to it. And like Dr. Sheila said, very, very difficult to, it looks so easy, but the delivery of the tube is what is tricky. So once you get the hang of it, then you'll be able to use it in difficult airway. If you use it for the first time in a difficult airway, you may not succeed so well.
Okay, thank
just
you,
one
Dr.
point,
Sheila,
when
Dr.
you're using the bougie, a lot of studies show the bougie, but I'll tell you one thing. The other very frustrating thing, sometimes when you use a bougie, you get an excellent view, but again, the bougie is also slipping down and going, into the esophagus, and you're not getting through. So it depends on what type of bougie you're using. If you have a bougie which you can pre-shape or with this thing, then you can get the same success as with the stillet. But otherwise, when you're using a D blade, using a bougie may not always be successful. So I would say between the two, when you're using a D blade, always try to use the stillet.
No, I
Thank
was
you, Dr.
talking
Sheila.
about the Mac VL, not the D blade. Yeah.
Okay.
For
So
normal
there are a
visualization.
couple of discussion and queries about nasopharyngeal airway. Dr. Naresh Paliwal had used small size endotracheal tube as a nasopharyngeal airway for oxygenation. And Dr. Bankim Shah has asked that if unanticipated difficult airway mask ventilation, are we underutilizing the nasopharyngeal airway compared to supraglottic airway? So, earlier we were having nasopharyngeal airway, which was also put for better mask ventilation. So, between SG and nasopharyngeal airway, is there any?
I don't think anyone is just directly putting in a supraglottic airway device. Of course, when we have difficulty, we put a oropharyngeal or nasopharyngeal airway. But definitely, once you put in if it's really difficult and you put in a supraglottic airway device, you can have hands-free ventilation. So that makes it much easier, and the chances of success are higher. So it is not that every time you have a difficult mask ventilation, you're putting in supraglottic. So it really depends on what you have available and what you're familiar with. But whatever you use, the endpoint, the goal should be to achieve successful ventilation.
Thank you, Dr. Sheila. Dr. Chandan is asking, many times I also seen personally that instead of 15 liter, we put 5 liter, 6 liter, 10 liter,
It doesn't help. People say I'm using nasal apneic oxygenation. So you start with 15 liters. So this is recommended by Richard Levitan, and there's no DSAT technique using the nasal cannula, nasal oxygen, no DSAT, nasal oxygen during efforts at securing a tube. And this is 15 liters. And you can use up to 15 liters because it's that much of dry oxygen is tolerated. But if you're going up to 30 liters, like when you're using high flow nasal oxygen, then of course you need heated, humidified oxygen to be delivered.
Yeah, Dr. Anita, she said that nasal airways should be included somewhere. I think Dr. Sheila can tell you because we have included it in that,
What is that?
technique.
Sorry?
Nasal airway should be included somewhere in the guideline. I think
It
it
is
is
there.
part of.
Nasal airway, oral airway, all these efforts at, when you have initial difficulty in mask ventilation, increasing the depth, giving muscle relaxant, using airways, and then, probably
Changing tool technique and the operator section has actually mentioned.
If you see that part where we've said that don't keep on doing the same thing again and again, change the tool, change the operator, change your technique or change the operator. So if I'm using a DL, I have to switch to VL. Sometimes just change the operator and you'll be able to have a success. So again, you can't keep doing the same thing again and again. And that's what happens when you're very, very stressed, that you keep trying to do the same thing again. And somebody else comes and says, okay, why don't you do that? Why don't you do this? And they're thinking a little differently and they're out of this stressful situation.
Okay, I'm just looking at it. There is one question even in the YouTube live video. Any teachers can answer. What is the optimal position during intubation in an anterior larynx case? That means if you have a difficulty And probably Dr. Whoever he is, meant probably with the direct laryngoscopy.
Yeah, so there's, anyway, if you're talking about unanticipated, I wouldn't say any optimum position. We pre-auction it at 20 degrees. We could start with this thing, but you're using a video laryngoscope in that kind of situation. So it doesn't really matter, about your position doesn't really matter so much.
Yeah. Dr. Kishore has asked actually two questions. One was about, suppose you have done only one attempt at each probably, and then you have a fall of saturation, what to do? I think Dr. Sheila answered, but she can again specify. You have a one attempt at each, and but the saturation is falling. So, like, should we go straight away to trico, instead of completing the circle of 3-3-3?
Right. So, again, that is the maximum number of attempts. But when you say maximum number of attempts, that doesn't mean that you have to do 3 times intubation and 3 times. That is a maximum. You should not exceed this, right? Because the reason we need to limit the attempts is that there's trauma, and you can convert a can ventilate situation into a cannot ventilate situation, which you don't want. So that is the reason we say, otherwise you can just go on reauctionating and have 8-10 attempts also. But we know that there's trauma and there's edema, and then you may not be able to ventilate. Now, it again depends, because you're changing your technique. You're changing, I may not have given muscle relaxant. Now I may give relaxant. Now I may be able to be successful. So my first attempt in mass ventilation may not have worked. But the next time I go, because I've increased the depth, because I've given muscle relaxant, it may be successful. So I need not exit the orange box. I can keep on trying to reauctionate the patient. But of course, you have dangerous fall in saturation, bradycardia, acute deterioration. You can rapidly proceed to neck rescue and do a cracotherapy.
Okay, there is another question from Kishori that, again, you can emphasize circular versus linear approach, which was there in 2016 to, change over to the circular approach, which we have done,
Well, I think this is one of the most important and most, I think, beautiful part of our guideline, that we don't have that hierarchy, and we don't say that it starts with a cannot intubate situation, because anesthesia is all anesthetics today. We are not about intubation. So wherever you are, whatever you are doing, whichever technique, you can start anywhere, but you have to use these 3 lifelines without any hierarchy. So that is the importance, because this is very practical, because people used to tell us, oh, I'm doing my cases on TIVA. So, oh, I'm just using a nasal cannula, and I'm just using a high flow cannula with propofol. So if my patient, obstructs or this happens, then what do I do? So it doesn't matter what you're using, you come into that circle. So that is the beauty of this. And then, otherwise your guideline, if you start with a linear, vertical approach, will never encompass all the scenarios that we are doing in modern anesthesia practice. Yeah.
So I think there is a question by Dr. Kumud about airway management in trauma with bleeding and facial fractures. So,
Yeah, so this is very important. As anesthesiologists, we shouldn't be very heroic and think that in every situation, I have to secure the airway. Okay, that is the wrong approach. There are some situations where under local, you should do a tracheostomy straight away. Okay, any of these techniques, video laryngoscopy or flexible bronchoscopy, blood and secretions are the enemy for these techniques. And the success rate is very low. So if you have a lot of bleeding and you have maxillofacial, like trauma, leaf-on fracture, the most safest option for the patient is do a tracheostomy under local. We don't have to always secure the airway from above.
Trauma, always surgical airway, keep a low threshold for that.
Yeah.
And mid-phase fractures is gonna pose a big problem for intubation. So maximum 1 attempt, but if the fractures are unstable, go in for a surgical airway. That is the
Can I make a comment at this point? Madam, I have one plastic surgeon who refuses you can't even take consent for an emergency tracheostomy.
Oh my God.
Maybe
he refuses even a consent for emergency tracheostomy. And it's all maxillofacial trauma, bad maxillofacial trauma, mid-facial trauma, Lifford 3.
So let him go through the ATLS guidelines. Just tell him to go through the ATLS guidelines. I think he needs to do that. When we have very
ask him to manage his cases.
He needs to. Achha, Dr. Amit, there's one question here, I think, which you probably missed. This person, doctor, is asking, where's it gone? Is there any role of ultrasound in the algorithms?
Yeah, I missed that.
Ultrasound in the algorithm, Muthu Kumar is asking. Yeah.
So in the acute scenario, especially when you're doing, so there are a lot of role, there's a lot of role of ultrasound in routine airway management, but in an emergency, sometimes even locating the cricothyroid membrane can be difficult. In fact, in anticipated difficult airway, it's always nice to use the ultrasound, locate the cricothyroid membrane, even mark it. Some people even put a needle, so we could use ultrasound for that. But in an emergency, especially when you have, say, in our kind of setup, in cancer setup, you have lymph nodes, you have deviated trachea, you have, so quick ultrasound can help you locate the cricothyroid membrane to perform a quick cricothyroidomy. So that I feel is one of the most important applications for the ultrasound in the unanticipated difficult airway situation.
Yeah, he's asking, is there any role for these in the algorithm? So do we need to put it in the algorithm? I think that's what he wants to.
So it is in the text, but if we start putting it in the algorithm, then everybody will try to spend time taking the ultrasound machine and doing the ultrasound where they can, directly do the cricothyroidomy, right, and not wait for that. So yes, in situations where there is difficult neck anatomy, definitely it will be helpful. So it is there; it's already there in the text. There's a whole section on ultrasonography, and
I think Dr. Kumar, the difficult airway, we are many times marking the cricothyroid membrane before we induce the patient, so that if the neck anatomy is short, thick neck, or there is some edema or something, and we feel there may be a problem, then sometimes we are marking with the pen.
Yeah,
but why should it not be mandatory for every patient who has to undergo intubation? Why should we not get into the habit of marking the cricothyroid membrane? Because unanticipated intubation will not tell us ahead of time.
That may be a bit of an overkill, but let me tell you, you're anticipating also, people don't do it, right? So Richard Levitan has described a very nice method, what you call the laryngeal handshake. The larynx is a rhomboid structure, so you move it from side to side and move your index finger, and you can. So routinely, when we're doing awake using a flexible bronchoscope, we make them give a translaryngel using the laryngeal handshake to familiarize them, because otherwise in the emergency they won't be able to identify. So it's a very good practice to do that with your trainees. Just one point I want to say, we've talked about the unanticipated difficult airway situation, but if you read the adult guideline chapter, it has a lot of text on routine airway management practices, like you mentioned, Madam, pre-oxygenation, apneic oxygenation, how to use mask vent, how to optimize your mask ventilation, how to optimize laryngoscopy. So all these usual airway practices, updated recommendations for all of this is given. So there's a lot of even ultrasonography, when to use it, what are the applications. So all this is very useful content, and I really urge everyone to read the text in conjunction with looking at the algorithm.
I think we are really running behind. There's a lot of good, excellent discussion. So before we switch, yes, Rakesh.
Can we have some comments from Dr. Vaishali and Apnita also?
Yeah. Thank you very much, Dr. Shaila, for an excellent talk, actually, and updated guidelines on this difficult airway management in these patients. Actually, I just want to know, because in obese patient mainly, there is a lot of difficulty during the mask ventilation. So what do you suggest for the PGs? Like before taking the patient inside the OT, you would like to mark them with the cricothyroid membrane, or just keep your USG machine by the standby like that?
Well, if I'm anticipating that this may fail, well, I might.
Maximum times it will be difficulty for the mask ventilation in obese patient.
Especially if they have short neck or difficult neck, anatomy. I think you could do it even routinely as a practice if you have the, it's elective. But definitely all your techniques to optimize mask ventilation and that pre-oxygenation is really important. Giving the ramped up position is really important. And also adequate time for pre-oxygenation and using various adjuncts to the technique, nasopharyngeal airway, oropharyngeal airway, and positioning the patient in the ramped up position, I think is really important.
Okay. And what about code D that you have mentioned, actually? So how you are practicing at your institutes? What exactly you are doing?
So, if I'm saying, there's an emergency, come to OT9. If you say code D, they know it's a difficult airway situation, right? Emergency can be anything, no? In the operating room, there can be bleeding, there can be something, you might need a situation where you need a surgeon there. So code D, when you specify and you say code D, it's a code D, that means a difficult airway situation, right? So the person who's running also for help already knows that this is the problem, right? It is an air situation. Person could not ventilate or could not, can't oxygenate, or now we're losing the airway. So you come mentally prepared knowing. So it's a good phrase to use, code D, code D. Like when you say code blue, it is, or you say code orange or whatever, it's a fire, So it's very specific. So we thought, why don't we have something for airway and why don't we popularize this?
And you also mentioned the additional help that what you have mentioned is complete ventilation failure. So
Yes.
what exactly we expect for this additional help? Actually, for the PGs, I just want to know.
No, absolutely, absolutely. So, like initially only when you face the first difficulty, you should call for help. If you haven't already, at any time when you remember to call for help. The faster you call them, earlier you will have help available. But in this situation now, I'm proceeding to complete ventilation failure. At that time, you call for one more person to come. You tell them, call whoever is there, whichever person, because this person can really help all those people who are in a messy situation. You need people who are not in this mess to be part of that airway management plan, because all these people, there's severe cognitive overload. They are very, very stressed. They are very worried that the patient is going to have a hypoxic event or going to die. So you need someone who's calm and cool, not only an extra helping hand, but you need someone else to come in and be calm and not be part of the stress and think rationally at that point, which is not possible when we are very, very stressed. And we ourselves see that, as experts also, as very senior people, when we are very stressed and we can't secure the airway, we go on doing the same thing again and again and again. We ourselves do that because we are not thinking, oh my God, I should use this, I should use
come out. Now, one more thing, actually, I just want to add, like we are more emphasizing on the difficult airway for the intubation or putting the LMA. Like this is just a part of discussion. If you have already given the schooling and you are finding it difficult to intubate, and this is a elective case, so it is also possible that you can come out, the patient can come out of the anesthesia, and you can discuss with your surgeons also whether you really need to go ahead for the intubation or some alternative airway. I just want to know, like for PGs, like if the elective case is difficult airway scenario is there, they have given the schooling, okay, and they are not able to intubate the patient or put the LMA like that. That situation is there. And after giving schooling, 5 to 10 minutes, patient will come out of the muscle relaxant effect.
That's actually not the case always, because the time to action of scoline is very rapid. But scoline, to come out of scoline, sometimes it may take even 8 to 10 minutes. It really depends on the patient, right? So, this is a myth that you think they'll come out very fast. Of course, relatively shorter than other muscle relaxant. But, the dictum today is that if you're in a situation that, you can quickly bail out, it's okay. But otherwise, you continue with the muscle relaxant. So, and
that is what they have mentioned in the AIDAA guidelines, you continue with the, but at that particular step, whether it is possible to come out of that scenario, if it is the elective procedure, that is what
the pathway, and you're with your back against the wall. Everything has failed. Intubation, supraortic, everything has failed. Now your only option is to do the emergency cricotherapy, which you're doing in the first time in your life, probably. And here, you want the patient to be absolutely relaxed. Your chance of even the last successful mask ventilation being successful is if you we know the compliance increases. We know the chance of a successful mask ventilation. Even when you see the trainees, when they first learn mask ventilation, you see how they struggle when you've just given propofol. But the moment the muscle relaxant acts, the mask ventilation becomes much easier for them. So, it's going against dogma, what we, initially practice, that, when you can't ventilate, give muscle relaxant is what we advocate today.
Because that is a very critical situation. Many times the PGs, they are a little bit reluctant to give the muscle relaxant if they are not able to ventilate the patients. So I just...
Okay. Dr. Neeta?
Yes, thank you, Doctor. Thank you, Shaila Madam, for reducing the difficulty level of unanticipated difficult intubation scenario. I have one question. Am I audible?
Yes, you are.
Yes, I have one question, that when we were discussing about the pre-oxygenation or para-oxygenation, so what is better? It is nasal cannula or nasal catheter?
Or nasal? So
Catheter.
that is not for the pre-oxygenation. For the pre-oxygenation, we use a face mask, right? The nasal cannula that I was talking about is for the apneic oxygenation. To continue.
Yes. To continue para-oxygenation.
Not to use the nasal cannula for pre-oxygenation. You can use a face mask, and then continue with the nasal cannula during attempts at securing a tube.
So is there any difference between the cannula and catheter? Catheter we put into the nasopharyngeal cavity, and cannula we just put over the nasal opening.
You can
So
use
is there any difference?
what is easy and readily available is the nasal cannula. So simple prongs that you can just put in the nostril.
Nasal prongs.
All the way into the nasopharynx. But if you have oxygenation has been technique oxygenation has been described with the catheter, with the nasal prongs, with all these devices. As long as you're giving oxygen during apnea, you will be able to prolong the safe apnea time. Some people use a nasopharyngeal airway. So different things are used to give the oxygen.
And thank you for the clearing the doubt about my doubt about the MAC blade and D blade. So there was always confusion that in case of difficult intubation, which blade one should prefer.
If you have a difficult intubation, I would straight away pick up the D blade. But for routine intubation, using the D blade for all patients, I would use a MAC blade. Unless you're really experienced to deliver the tube, it would not be worth using the D blade for all patients.
So according to you, what is the disadvantage of D blade? Like what is the problem? What is the difficulty of D blade?
Yeah, the D blade is a little more bulky, okay, because of the curvature is. And it actually makes intubation difficult if you are not trained to deliver the tube. So training is very important with use of a D blade. Whereas a MAC blade video laryngoscope comes very naturally because you're already using a Macintosh laryngoscope. So it comes. But D blade intubation needs training. So if you are trained to do that, then it will be easy. But otherwise, it will make your intubation difficult.
Okay, thank you.
Okay. Over to Rakesh. While I, load the Kahoot.
Thank you so much, all the chairperson, for taking such an interactive session of an important topic of airway management in adults. Thank you so much for your insights, your personal experiences that you have shared. And I fully understand that the many decades of your experiences of 3 or 4 decades has given us great insight into understanding of the airway management. Thank you so much, each one of the chairpersons. And thank you also to Dr. Sheila Nandanmitra to spare time. I know she is very busy in many other commitments. Thank you so much, madam, for coming up and taking us through the airway management guidelines.
My pleasure.
Keep tuned. Yes, madam. Stay tuned for the other aspects of guidelines. 2 weeks later, we will be having the AIDAA guidelines for obstetrics and pediatrics. Another 2 important aspects of guidelines. When we talk about obstetric patient and pediatric patients, they are not the same patient. They are not just female patient. They are not just small adults. They are absolutely different. And that's why AIDAA has come up different framework for management of airway in these 2 challenging situations. We will have the speakers directly from the guideline authors who has taken a lead, and they will be taking us through. And subsequent to it, another 2 weeks, we'll have guidelines on extubation, Code D, difficult airway cart, which is again an important aspect when we talk about airway management. So thank you once again to each one of you. And now we will continue with the quiz on the Kahoot platform. Another interesting quiz, just to inform the participation to quiz is absolutely free. Each one can participate. The link is already there in front of you. Each participant will get a certificate of participation. And we have shared a link there. If you can fill it up, you will also get a discount coupon of ₹1,000 for registration to the National Airway Conference and International Airway Management Meeting, which will be at AIIMS, New Delhi. Very interesting one, and more than 40 international faculty are joining, apart from more than 100 faculty from India. So it will be a very massive faculty get together with a lead role. So we have a pin mentioned. The pin for game is you can directly log to kahoot.in, www.kahoot.it, and the game pin is 3416192. So this will take you through the Kahoot quiz. Moment you fill out this pin, I repeat it once more for you, 3416192. If anybody is having a problem, they can put up the message in the chat also. So log into www.kahoot.it and enter the game pin for today's quiz is 341619.
We are getting more and more responses.
The winner of today's quiz will have a chance to directly enter the grand finale at National Airway Conference, and all will be getting participation certificate. Top 3 will get a winner certificate also through the email.
If anyone is facing difficulty, they can put it in the chat box. Those who are still, because there are at least 12 viewers in the YouTube, you can also log into Kahoot and then put this pin. So you can also straight away join here. Or if you are still in the YouTube, there are now space available in our Zoom, so you can re-log into Zoom itself also, because earlier we have crossed our limit, so some of them had to actually log into YouTube. Okay, I think Rakesh will wait for 30 more seconds.
Yes, sir.
People are still joining, and they can also join later on also. It's not that they cannot join. Today's quiz, Kahoot would be, I feel that all the questions, all the answers have been given by our esteemed speaker and the chairpersons. They already discussed through it. So speed will be something which is going to be sort of matter today. Most of the time you would be knowing the answers, but the speed matters. And some of them we have really kept a very short duration of 10 seconds also. So be ready. Keep your fingers on the button. I'll just wait a few more seconds and then we can start. Okay, we're still getting more. Wow. So we still have 60 plus participants. So maybe we can cross 45, 50. Just wait for a few more seconds.
Some of the participant is mentioning difficulty. In case if you are not able to click with the link, just type www.kahoot.it, www.kahoot.it. Moment it opens up, this will ask for a game pin, and the game pin for today's quiz is 3416192. So you can directly enter through that also, and we have shared one link into the group, so you can enter through that also. So both will take you through the today's quiz.
I think we are settling on 42, Rakesh. We can start.
We can start, sir.
Okay, so let us start.
So ready, set, go.
So again, this is AIDA's National Airway Conference 2026 and IMM 2026, which is 9th, 10th, 11th October 2000 at AIMS, New Delhi. Okay. Thank you. Dr. Sheila Maitra, our chairpersons, and our quiz masters, Dr. Kiran Mahendru, Dr. Indubala, Dr. Shilpan, Dr. Shripad, for helping us with this excellent quiz. Thank you. So concentrate on questions and options. Images may not be the exact representations of those questions or answers. So concentrate on the text which is written for the option. Some of them questions are having double points. Some of them the duration may vary. Sometimes it is 10, 15 or 20 to make it interesting. So you need to be correct and fast to gain more points. Okay. So let us start.
So this means, Dr. Amit, if somebody answers fast, he will get more marks, right?
Yes.
Right.
Fast and correct.
Exactly.
Fast and correct. There are two things. Okay. Here we go. First one itself is double point. Puma and AIDAA. Out of 42. Fantastic. 29 of them is given correctly. And the leader is Arun with 1788 points. Okay. Wow. So the 2016 guideline was only primarily focusing on intubation, but 2025 guideline covers all other scenarios include of general anesthesia also.
So I think a couple of them have marked wrong. So be careful. Just go through these guidelines, and that's why somebody asked why circular and why not linear hierarchy. And that's why which Dr. Amit Shah and Dr. Sheila and all the chairperson emphasize. And that's the beauty of these guidelines, that it covers many aspects for a successful airway management in adult patients. So Dr. Abhishek has taken a leave, Dr. Amit now, and I think cheer up and a lot of points coming up.
As I said, fantastic, 100% correct. Wow. Okay, so Abhishek is still leading. Arun is right behind, and Shan is also there. Wow. So any sign of difficulty, you straight away, first thing you do is call for help. You don't wait for further to, things to fail or change. First thing difficult, you go ahead and call for help. Okay. So now Arun must have given answer faster than Abhishek, so he's leading. Now this should be 100%, but very short time. Code D is a correct answer. And let's see.
Oh, two said code A and one said code C.
There are two things. One is sometimes you tend to, push the button which is slightly wrong because they keep on changing, So Arun is still leading and Shan has catch up. Okay. Okay, 33 out of 36 have given correct answer. A video laryngoscopy should be used because it has a higher first pass success.
So I just like to add that Stilett should be used. And what was the other one?
Yeah, Stilett should be used. You
And
should
let's
be
pause
familiar.
with-
You should have device. Yes,
Let's
ma'am.
pause with video laryngoscopy.
Yeah.
So
Okay.
both the last two answers are wrong.
Don't nowadays in airway management, we usually don't save for blind passing of anything, including the bougie. So bougie should be guided.
Okay. Only 15 seconds. I think everyone has given answer very fast. Okay, so 95%. Most of them has given answer. Only one has probably 85%, but 95% is a cutoff point. Okay. Come on. Those who are on 4-5 number are also very narrowly, on that number. Maximum attempt per airway device before the next step. Got 42 answer already by almost 10 seconds. 41 said yes, 3 attempts. That's absolutely correct. It's not 2 attempts with each device. It is maximum 3 failed attempt. It's not necessary that you go to all 3. But yes, if you are able to maintain everything, you can do maximum 3 failed attempts. Okay. They're still leading. Arun is still leading, but very narrowly Snehal and Dr. Sai is there. You can catch up. There is one question which is going to be double point. Now this is tricky. Read carefully. Here is the query. So basically, yes, Rakesh, you want to comment? Dr. Sheila, madam?
Yeah, I would like to comment. So this is when all your 3 lifelines fail, that is the tube, SGA and mask, and even when your saturation is preserved. Okay, so it's not when hypoxia sets in, that is it will be KICO. We are talking about even when your saturation is 100%, once you fail ventilation, that should be your trigger to start an emergency cricothyrotomy. So the correct answer is 1. And some people have said failed intubation and SGA, saturation not maintaining. Well, we also include the mask because we have 3 lifelines. That's why the last answer is not this thing. And remember, in all these 3, in the blue and the green, we're talking about hypoxia. We are talking about preserved oxygen saturation. That's the trigger. Even when
it is possible that saturation may be preserved because of apneic oxygenation, but still you go ahead. You don't wait hypoxia to occur or saturation to fall for after failure.
As I mentioned, ventilation failure precedes the oxygenation failure. So that should be your trigger to perform emergency cricothyrotomy.
We also clarified in the previous question, it's not that you will be attempting the maximum of attempts with each tool. If the saturation starts falling, even then it will be labeled as complete ventilation failure. If saturation is falling, you can think of the next step, which will be the surgical air.
Okay. Arun is still leading. Snehal has come up on the 3rd. Okay. So there are 3 more questions. What is now fixation? Fantastic. Okay. So busy, Dr. Sheila?
Human failure factor considerations, right? When you go on and on doing the same thing without any success, so there's cognitive overload, and this is why you do that. So it's nothing to do with any equipment, oxygen, or drug error. You're fixated on a task.
Okay. Arun, Abhishek, and Snehal, there is a tight competition going on. Double point. So this allows you to take. So what options describe AIDA's critical language? So this, I think, Dr. Sheila has also mentioned. Most of them is given correct. Okay.
Language is what you use in an emergency, so it should be very clear, it should be universally understood, and it should be self-explanatory. So when you say emergency cricothyrotomy, it's very clear to everybody it's an emergency. And when you say cricothyrotomy, people know what is a landmark, anatomical landmark. So it's self-explanatory, and it should be universally understood, right? If I say cacophona, people may not understand what you're talking about. So it's not about using abbreviation, but clear, universal, and self-explanatory terms.
Yeah. Okay. Okay. There's still competition, and I think
Arun is consistently leading, yeah. But
yes. The last question. I think this is,
what is the before taking according to
Okay, so the answer is really clear. There should not be any confusion, and I think we have extensively.
Again, it is preferred, so it's not that needle cricothyrotomy is wrong. So in the preferred, it is among the techniques, surgical should be preferred, but you can also do a needle cricothyrotomy. And remember, tracheostomy is not emergency airway access at all times, because it does take time. It needs a surgeon, it needs cautery, it needs light, it needs the operating room. So it's not really emergency airway management. But in the situation where we have said it is still possible to do a tracheostomy is if you have a ENT surgeon or someone who's very experienced to do a tracheostomy, absolutely there by the side of the patient, then we may permit a tracheostomy even over above a surgical cricothyrotomy, because you have an absolute expert there to do it. But this might not be the situation with any other surgeon. So in this situation, a tracheostomy may be considered. Otherwise, a surgical cricothyrotomy should be the preferred technique.
Okay, thank you. So I think that takes us to now let's see the winner. Number 3, Snehal Patel. Congratulations, Dr. Snehal. Second number, Dr. Abhishek. And the winner, Dr. Arun. Wow.
Arun has been consistently on the top.
Okay. I'll just close this and over to Rakesh, sir. Sir, you can conclude.
Thank you so much, sir. Thank you, everybody to join us for this AIDAA Quizinar, and after an interesting session of the webinar aspect, taking up the first guidelines on the airway management for adult by Dr. Sheila Nayan Mitra, with all the senior chairpersons who has taken the great insight into the guidelines with practical experiences and various cases. So thank you each one of you, and thank you each participant for joining. I think it was a huge number. I think I would request General Secretary AIDAA, Dr. Amit Shah, to think of increasing the Zoom participant to allow more than 100. But anyhow, we have opened up in the YouTube, which is again the channel where you can also join in subsequent days. And thank you each one of you for so much actively participating for this quiz. I'm sure you must be enjoying it. If you have any feedback, how we can improve on further, please communicate to me or Dr. Amit Shah at the emails mentioned on the AIDA website. And also, each participant will be getting a certificate. Winners will also be getting a certificate. And I request once again that there is a link of the Google form. If somebody of you have not filled it up, please fill it up. Only those who fill up, it is free, but it is mandatory. Those who fills up this form will be getting a participation certificate. 3 candidates will get a winner certificate, and each one of you will get a special discount of ₹1,000 for registering to the National Airway Congress 2026 at AIIMS, New Delhi. So thank you once again. And last question before we wind up, Dr. Sheila Mehta, madam, why 6 number ETT tube used for surgical airway? Why specifically 6?
Right. So it is, you don't want to use something very small because then that will be like a narrow bore cannula cricothyrotomy. So we would want to use something bigger, but at the same time, you don't want to use like a 7 or 8 number, something like really big. So 6 can give you a kind of, it's not really evidence-based or something, but it can give you effective ventilation. So that's the reason why, universally, the consensus, it's more a consensus that to use a 6 number tube. So nothing evidence-based in that, but with 6, you can have reasonable ventilation as with any other endotracheal tube.
What I believe is that, 6 size outer diameter is less than 1 centimeter or around 10 mm. That is the area which is available in the cricothyroid membrane. Okay. So if you try to put bigger size, the cricothyroid membrane is not.
Yeah.
So, and the smaller size would have difficulty with the ventilation. Okay.
And that's a very important point because remember, people always say transtracheal. You are going translaryngeal. You are going through the cricothyroid membrane. That's a very important point also. So, that's not routinely where you do the tracheostomy. The tracheostomy is done much lower. So that is also a good point for using a smaller tube. Also because of piece of insertion.
Yeah. And also another important point is that smaller than that tube, you will have difficulty in threading over the bougie. So this is exact size which can be easily threaded over a bougie, and it is not big, so that it is. So this is good in exact size which can be passed through cricothyroid membrane very easily.
Size 5 will be a very tight fit. So that's
so bougie, it will be a very tight fit.
Yeah.
So we close with a very interesting question and very relevant answer to this. Thank you so much once again, and see you next Tuesday with another interesting talk by a very popular personality. We'll share the flyer very soon. Keep tuned in, keep learning. Let's share the airway management. Let's provide the safe airway management to our patients, and let's enjoy the Cuisinar. And one again, we welcome the All India Difficult Airway Association welcomes you all for the National Airway Conference 2026 at AIIMS today. Thank you so much and good night.
Thank you.
Thank you.
Thank you. Thank you all. Bye-bye.
Good night.